Okay, let's discuss neurological imaging procedures. So it's important that we immobilize the patient's head before we do any kind of imaging. We want to make sure that we inform the patient they need to hold still. This is a key part of communicating with the patient, especially if they're agitated or you suspect some kind of dementia or difficulty in comprehending instructions. You may have to stay with the patient and in some way assist in supporting them through the exam. But generally for most patients, just clear instructions will help them remain still. We want to program the slices so that they're parallel to the supraorbital meatal line, and that's primarily to reduce radiation exposure to the lens of the eye. So if we look at page 240 in our textbook, we see that supraorbital meatal line, and it's important that we center appropriately for these exams. That's going to be site dependent, machine dependent. Likewise, some protocols call for images to be taken in a direct coronal plane. Pretty rare, but we're talking about sinuses, things like that. And maybe the temporal bones, TMJs. We don't do very many TMJs anymore. Most of that goes to MRI, but we might still do temporal bones. And in that case, we might want to have coronal, true coronal. And so if that's the case, we're going to have the patient lying prone on the exam table with their head tilted up. But for most other procedures, we're just going to have the patient lying supine on the exam table. And so the key point here is that we want to make sure that the patient's correctly oriented. So you may hear some of the text talk about Tom, the little CT guy that we can orient on the exam table. We want to make sure that he's oriented appropriately before we begin scanning. Otherwise, our images are going to be mislabeled, and it's very difficult to correct that retrospectively. So, because of the dense bone in the skull, beam hardening is like an inevitable thing, and there's protocols in place on most scanners now, most new generation scanners, to account for that with the processing algorithms. But the artifact's going to be seen most prominently in the posterior fossa, and so we may have to window. You'll notice there's certain windowing protocols that may help us see beyond that artifact. And we can look at different window levels to account for that, or we just may want to try to do thinner slices through that area. So it's important for us to evaluate the images after the exam and make sure that that if we need to, we may have to scan through that again, or maybe even we used to do butterflies through that area where we would tilt the gantry to account for certain kind of beam hardening artifacts, particularly like a spray artifact from teeth. But routine head studies are most often done with the step and shoot, so like an axial mode, and that's to account for the gantry tilt. Helical mode, like the volumetric imaging, is going to be used for any kind of 3D reformats or CT angiography. So like if we're looking at the circle of Willis, or if we're trying to do an angio of the neck, we need volumetric data at pretty thin slices so that we can do 3D reconstructions. And then because of the small difference in attenuation between gray matter and white matter, to view the images of the brain, we're going to need a narrow window width right at the level of brain tissue. So if we look at page 240 again in our textbook, it gives us the different X-ray attenuation in Hounsfield units for these things. So we're talking about a window level of about 30 and a pretty narrow width of like maybe 100 to visualize everything that we want to see in the brain. Okay, if we're suspecting an intracranial hemorrhage, CT is a very frequently used exam for that, just because it's so quick and so specific to that. So the appearance, nevertheless, of any kind of intracranial hemorrhage is going to change with passage of time. I think there's a really nice illustration in our textbook on page 241 of how the initial bleed is going to be hyperdense, so it's going to be denser than brain, so it's going to show up white on our images. Eventually, as the tissue is damaged, it may become isodense, so equivalent to the way that brain appears. And then as it becomes completely necrotic and the blood becomes old and dead, it will just be hypodense, so then it will be black on our pictures. So in general, this is going to change with time. So we can see these first 3 days are critical. The strokes are going to show up bright white, and then it will become isodense, like upwards of 6 months out. So a lot of these patients are going to be coming to us through the emergency department, and the radiologists are going to be reviewing it, within a brief period of time after the exam. There's going to be some patients every now and then who might show up with less acute things like a headache, and they might just come in as an outpatient. So it's really, really critical for us to consider the pathology of bleeds and CT scans as X-ray techs. We're not making diagnosis, but we need to be informed about different kinds of bleeds so that we can evaluate these images for the presence of blood, and tell the radiologist, hey, look, I think I see something on these images, so that they can very quickly review the images and make the calls necessary. So we play a vital role in bringing the scan to the radiologist's attention. So the next slideshow, we're going to look specifically at pathology in the brain, because there actually is legal things guiding us to make those determinations. So general imaging methods for the neck, we're talking about having the patient positioned supine. We want to have the chin up. Having the chin up will help us keep, again, the eyes up out of the area that we're scanning, hopefully. We're typically going to be considering these volumetrically, so we'll be scanning in a helical mode. And I mean, just as a note on that, pretty much the only thing that we scan anymore in an axial mode is going to be the brain. Everything else, we're typically looking for volumetric data. We may use IV contrast, particularly if we're looking for any kind of infection or cancer, unless it's contraindicated due to the patient's history, stuff like that. Some institutions like to do a split bolus injection, and that just means that you do an initial bolus injection at maybe 3 milliliters per second, and then you slow it down. You after you've injected 50 milliliters at 3 milliliters per second, you might slow the injection rate down to 1.5 or something in that ballpark. And the idea with that is that if we're looking at soft tissue structures in the neck, that allows us to evaluate both the arteries and the veins. So, nevertheless, the goal is to allow for sufficient time after contrast administration to evaluate mucosa, lymph nodes, any kind of pathological tissue that might enhance, and still view all the vasculature. So, common carotid arteries, vertebral arteries, and then jugular veins, things like that. Now, that was a soft tissue study. If we're talking about a CTA of the neck, then we're just interested in the arteries. We don't want any kind of venous contamination on these images because it makes post-processing a little bit more difficult. Sometimes it can get in the way of our read, and we may not get a good peak contrast view just in the arteries. So a lot of times we'll be setting a bolus tracker on the arch of the aorta and scanning from the feet to the head through all of the arteries in the neck, and we're going to want to get through the circle of Willis. So any CTA of the neck, sometimes doctors will order CTA of the neck, make sure to include the entire circle of Willis on those images, unless your institution says otherwise. Most institutions, if they order a CTA of the neck, they're getting a CTA of the head and the neck, and typically it's going to be without and with contrast. So we'll do an initial scan without through the head and neck, and then we'll do the angio study of just the arteries through from the arch of the aorta up through the circle of Willis. So it's a less invasive procedure, as you can imagine, versus a traditional angiography. It's widely available. Any scanner from a 16 slice up is going to be able to perform these procedures pretty nicely. It's less expensive, very time saving. So we can really quickly get a patient in and get them off the table for this about 15 minutes. So we get some really nice high resolution pictures from this while the contrast is in the arterial enhancement phase. So that's going to be kind of our bolus phase, right? And the goals are to accurately measure any kind of stenosis of the carotid and vertebral arteries and their branches, and to evaluate the circle of Willis completely. And a lot of times we're going to do some kind of 3D reformat, some really pretty reformats, kind of post processing at like a Terra Recon station, or and then also we'll do MIPS. We may be able to see other vascular lesions, and then occasionally I've never done one of these CT venographies, but if you want to do that, you could, I guess, to assess for venous anatomy. You're just going to, you would probably still inject a bolus pretty rapidly, but you're going to delay the initiation of the scan. So I might set my bolus tracker now off of the jugular vein so that I make sure that I've got nice jugular enhancement, like venous enhancement of the contrast versus arterial enhancement. But that's pretty rare. Okay, spine protocols. So if we want to actually just look at the spinal cord itself, MRI is kind of the modality of choice for that. But if we're looking for bony abnormalities, like patients in a motor vehicle crash, or there's a bone suspecting a bone spur or something like that, or fracture, of course, we're going to want to go to CT. So trauma C-spines are really common. We used to do those in X-ray. A lot more often they're coming to CT because we can do their head and their C-spine, and the time that it would take us to do just the C-spine in X-ray. Proper localization is really, really important for these scans, and we want to make sure that we scan an appropriate amount of information above and below the area that we're interested. For instance, if we're doing the L-spine, we're going to make sure that we can see false ribs so that we know that we're at T12, and we want to scan through the sacrum. So that we include all the important anatomy. We don't want to clip any anatomy. We don't want to create a field of view that's so small that we clip a portion of the anatomy. And remember that the spine has kind of different curvatures to it, and so we want to make sure that, for instance, if pretty rare protocol, but if we're doing like a CT of the thoracic spine, we want to make sure that we have a field of view that's big enough to account for that lumbar curvature of the spine, or I can't remember the name off of the top of my head. I'm sorry, I'm talking too fast. Just make sure it's localized appropriately and that we don't clip any anatomy. Make sure that all of these scans include AP and lateral scouts. Every now and then people get fancy and they skip a scout, particularly if we're doing like an abdomen, people will skip scouts, or if we're doing a brain, we just need to do the one scout, like a lateral scout. But we want to make sure to include AP and lateral scouts because that may be helpful to the surgeons or helpful to the radiologists. And visualization of the intradural structures is improved by intrathecal administration of contrast. So if that's the case, then typically what we're talking about is them doing I'm sorry, I just drew a blank on the procedure, but they're going to do a fluoro procedure prior to it, where they introduce IV contrast to the intrathecal sac, and then we'll come over and do the actual CT of their lumbar spine or whatever. That's if we just need to see the C-spine or like the L-spine or something like that. But generally those patients are going to get referred to MRI unless they've got like a pacemaker or something like that. So, intrathecal contrast administration. CT exams are performed after, that's it, myelogram. That's what I was trying to think of. Sorry, just talking too fast. So we're going to use a myelogram to enhance and clarify findings. So we want a delay of maybe an hour to 3 hours. These are great exams because you can kind of just lazily go over and get the patient and do the scan and you're done. A lot of times we want to have the patient roll around a little bit just to maybe further coat that. But we don't want them too active because we don't want to allow for any kind of leak of CSF fluid because that gives you a heck of a headache. But if the contrast is not spread around throughout the spinal cord, it may actually overly enhance, and then it would create, again, like a spray artifact, and it would mask intradural structures. So we just want to make sure that we have a nice even coating of contrast media throughout the area that we're scanning. If we suspect a stroke, so rewind back to the brain scan, and we'll be talking about this a little bit more when we talk about pathology. They're going to do some kind of lab test, and they're going to assess for acute ischemic strokes, and but basically the CT is the standard of choice to evaluate for that. So before they can give them this tissue plasminogen activator, this drug, they want to make sure that the person's actually having a stroke, because this drug is going to really take them on a wild ride. So nevertheless, to be effective, we've got to give them TPA within 3 hours of the first signs of a stroke. So this means that stroke victims must be transported to the hospital, diagnosed, and administered the TPA treatment in a 3-hour window. And then and if there's a intracranial hemorrhage, that would be a contraindication for the TPA therapy. Nevertheless, we've got a lot of these patients that are coming in. In fact, I mean, just the other day I was at Family Dollar getting some stuff. I noticed a woman, she seemed to be struggling. Her granddaughter was with her. She completed her purchase and fell out in the middle of Family Dollar. She was confused. I asked the granddaughter if she had diabetes. They both seemed to think that she had diabetes. We got her started on some sugar stuff while we called the ambulance. By the time the ambulance arrived, she still had not really come around. So I'm pretty certain that she had this kind of a CVA kind of thing. So, nevertheless, time is of the essence. So any place that is regularly treating stroke patients is going to have a stroke protocol in place, and that's the kind of thing where this is why we get paid the big bucks in CT. Is the minute that they call this code, or they believe that the patient may be having some kind of stroke, they need to get that CT scan. Stroke protocols require that they get the CT scan completed and read in 30 minutes. So knock people out of the way, get to that patient ASAP. They understand. Don't be polite. You got to get this person, you got to get information stat so that they can start a drug therapy if needed. So non-contrast of the brain is routinely performed to differentiate between the ischemic stroke and a hemorrhagic stroke, and to assess the state of cerebral circulation, tissue, and any kind of underlying disease. If we want to get really fancy, we can do these CT brain perfusions. That's going to be a little bit more time involved, because we're going to slowly inject contrast and evaluate how the brain is perfusing. These studies are the ones that the Cedars-Sinai made so famous, because they had their machines, their CT machines, set to at too high of a technique for the CT perfusion studies, because you're scanning the same place over and over and over again, and it's just above the eyes. And they had patients who were losing hair due to CT brain perfusion studies. So people are a little bit hesitant to order this study. It is a helpful study, but again, MRI might be a modality of choice too if we're wanting to see perfusion kind of stuff. But nevertheless, perfusion studies are obtained by monitoring the passage of iodinated contrast throughout all the cerebral vasculature, and we can see how it perfuses through the brain. We get these nice, pretty, colorful pictures, like rainbow-colored pictures of how the blood is perfusing. So, neurological protocols that we need to be aware of and get trained in are routine heads. That's probably the bread and butter exam, the one that we're going to see the most of in CT. Skull base, so like posterior fossa kind of stuff, and this would be if we've got beam hardening and we need to scan through that area again. Temporal bones, this is one of those pretty rare studies where we'll scan through it axially, and then we also might do a true coronal. Most of the newer scanners, if we get volumetric data in an axial plane, we can also reformat for coronal information. Sinus screenings, again, we used to do these axial and coronal, or maybe just coronal alone, depending on what the doctors want. If it was for surgery, sometimes they wanted, there were specific protocols in place, to do 3D reformats to guide surgical procedures. So just be aware that there are some special sinus protocols, but in general, most places they might just do a coronal through the sinuses. Again, that coronal scan could be limited by spray artifact from any kind of dental work. Trauma facial bones, and these are ones where we can do really fancy 3D reformats. Orbits, and then sella turcica. The trauma facial bones and orbits, again, this used to be the domain of X-ray, but we're doing it more frequently in CT now. Neurological protocols, the brain perfusion scan that we mentioned, pretty rare, but some places really like them. CTA through the circle of Willis, you'll probably be doing a lot of those. CTA through the circle of Willis, and including the carotid arteries. And then cranial venography, pretty rare. Soft tissue neck, we do a lot of those, especially if we're looking for infection or cancer, something like that. Neck pain, neck mass. C-spines, we do lots of those. Thoracic spines, not as much. L-spines, we do tons of those. And then CTAs of the spine, pretty rare study. Those patients are probably going to be referred to a different modality.